Should I continue my share?
Sure, yeah, we can leave it up.
Okay.
Hello, everyone. We're just allowing people to enter into the webinar and then we'll get started. Okay. So in the interest of time, I'll go ahead and get started. Hello, my name is Nellie Sabor. I'd like to welcome you to the Autism Intervention Research Network on Physical Health, the AARP August 2023 webinar on Neurology Node Updates, examining co-occurring neurological conditions and autism across the lifespan. So thank you all for joining us today. Because of the number of participants, your audio will be muted throughout the call. However, you can submit questions at any point during the presentation via the Q&A feature or in the chat box on the webinar console. Just a friendly reminder to please be respectful when communicating in the chat and asking questions, and note that only the questions or comments pertaining to the presentation will be addressed. The entire webinar will be recorded and will be available on the website, our AARP website, and you may also view the slides to the webinar, the presentation in the Google Drive, which I will put in the chat right now. There will be a short evaluation survey at the close of the webinar also. We invite you to provide feedback on this webinar and also provide suggestions for future webinars. So in the interest of time, again, let's go ahead and get started. So next slide, please. First, we'd love to acknowledge the Health Resources and Services Administration for funding, being our funding source for AARP. Next slide, please. Now it is my honor to introduce our presenter for today, Dr. Rujuta Bhatt Wilson. Dr. Wilson is a behavioral child neurologist specializing in autism and related neurodevelopmental disorders. She's a professor of pediatric neurology and psychiatry at the UCLA David Geffen School of Medicine and the UCLA Center for Autism Research and Treatment. Dr. Wilson leads the motor phenotyping core at UCLA CART. Dr. Wilson also leads the AARP Neurology Node. Dr. Wilson's NIH-funded research is focused on developing quantitative methods of motor phenotyping in order to improve characterization of motor development, better understand how specific motor impairments can impact cognition and language, and develop more targeted interventions for children with neurodevelopmental disorders. Dr. Wilson's work also extends to measuring the physical and behavioral benefits of organized physical activity for children with neurodevelopmental disorders. So without further ado, Dr. Wilson, please take it away.
Thank you so much, Nellie. I really appreciate that kind introduction, and I look forward to giving this talk today. As Nellie noted in the title, this is really an opportunity to provide attendees and in general those who will have access to this webinar with updates on what the Neurology Node is doing. And in a way, I'd like to say sort of a refresher of what is our mission, what is our research agenda, what are some of the activities that we're doing, and where we want to maybe go forward, or give those who are attending and those who watch a sense of if they have research interest in this area, how we might be supportive of it. Given that the fact at the inception of the Autism Intervention Research Network on Physical Health, Dr. Alice Kuo, the principal investigator, and all the node directors really had the goal in mind to be very collaborative and disseminate the type of research work that we're interested in to other universities and other partnerships in the community. So thank you again for attending today. As you all, many of you might know, now that I'm on the Zoom ShareLand, all the boxes get a little bit smaller. And so Nellie, what I might ask, if there's questions or comments in the chat, if you don't mind, if I don't see them, just noting them to me. I do not mind if people would like to comment or question throughout, but I'm also happy just to answer questions at the end.
No problem.
Thank you so much, Nellie. So I'm going to start with just reviewing what the Neurology Node sort of priorities and mission are. And what you're going to see is as we go through these priorities and mission, we're going to sprinkle in kind of each of our activities in no particular order, how we're hoping to know each of these priorities, achieve them, and expand on them moving forward. So our mission, the goals of the Neurology Research Node, are to improve identification, awareness, and intervention of co-occurring neurologic conditions in autism, with a focus on those that are more understudied and related to physical health and well-being, given the mission of the AARP. And our research agenda, very similarly, is our specific research priorities include understanding and addressing co-occurring neurologic conditions with the focus on those understudied and underscreened conditions, and disseminate information on these conditions and adult outcomes to providers. So both pediatric and adult outcomes. So when we look at some of our priorities, just see if I can get this to move over. So we have several priorities under that mission. Mentorship is a very key aspect of what we want to do, supporting researchers in undertaking studies related to the neurology node, with an emphasis, I want to say, on trainees and junior faculty, but really collaborating with anyone who's interested in this, particularly our collaborating research entities. We want to engage with the community. So the research that we do, we want to make sure it translates to those who would benefit from it most. So information on best practices to caregivers and primary care and subspecialty providers. We also want to understand neurologic conditions in adulthood. Those have largely been understudied, particularly in autism. And so it's important for us to examine and disseminate information about the occurrence of these conditions in adulthood, both to caregivers, individuals themselves who have autism, as well as primary care and subspecialty providers. I'm also going to highlight, and I highlight one here just because the neurology and genetics node led by Dr. Julian Martinez have opportunities to work very closely with one another. And one particular priority that we have is to identify and better understand genetic conditions that are associated with autism and often associated with many neurologic co-occurring conditions, and better understand why they occur and what treatment responses may be to things like epilepsy in these conditions. And as you'll see on the genetics node on our website, with a particular emphasis on rare genetic predisposition to some of these conditions. So here are some priorities within that, which I'll expand upon throughout this talk. But let's start back now with what are the co-occurring neurologic conditions that we often see in autistic individuals? And I should make note now that I will use both person and identity first language, both autistic individual and individual with autism. I will use terminology such as autism and autism spectrum disorder purely because of some of the research that I might be highlighting. And my main goal and focus is to be respectful of all and those individual preferences for anyone who does identify as neurodiverse and who might be associated with that. So co-occurring neurologic conditions are prevalent in autistic individuals and can present across a lifespan. To highlight three particular neurologic conditions that are common and their prevalence, we know that autistic individuals are 10 to 30% at higher risk for seizures compared to the general population. Studies have shown a range from 5 to 45%, with a somewhat agreed upon sort of percentage within our community of neurologists and subspecialty providers who take care of these individuals, that it's likely aggregates around that 10 to 20% higher risk, and the general population risk being about 1 to 2%. So certainly a much higher risk. Sleep disturbances, insomnia, difficulty falling asleep, difficulty staying asleep, and many other sort of sleep difficulties are reported in up to 50 to 80% of autistic individuals. And motor difficulties or differences or dysfunction or impairments or delays, several terminology been used for this, are reported to affect up to 30 to 80% of autistic individuals and can often manifest in a very heterogeneous manner across a lifespan, and is a particular area that you'll see of interest of the neurology node, and of course, particularly of mine in terms of conditions that are understudied and not as well understood in autism. So what are some gaps? Well, we know that there's gaps in awareness of these co-occurring conditions by healthcare providers, particularly the prevalence of these and how they can impact broader development and quality of life and physical and health and well-being. We know there's some areas lacking in terms of appropriate screening and referral for interventions as well. And we also know that there's sort of a lack of rigorous intervention studies in some of these areas, particularly in treating some epilepsy regression syndromes that might be associated with behavioral side effects, and also particularly in supporting motor difficulties in autistic individuals. Many studies are not as representative autistic individuals with varying intellectual abilities and varying adaptive function levels and co-occurring behavioral or psychiatric conditions Oftentimes those, particularly motor studies, those with intellectual disability or who are non-speaking, may be left out purely because of the difficulty in maybe measuring change or measuring response to treatment. And there's still yet a lot we need to know about etiology of co-occurring neurologic conditions and the cascading effects it can have on an individual's physical health and well-being. So focusing now a little bit, because I'm going to highlight first by providing an update on one of our core projects. The scope of the Neurology Node is wide, but one particular project that we had emphasized within our grant as a sort of 5-year-long project was an intervention study. And this is, in fact, kind of highlighting back the background that I gave, that motor impairments or difficulties are prominent in autistic individuals. And often they impact an individual's ability to engage in physical activity, which I'll go into more detail in the next slide. And we know that there's benefits of physical activity on health outcomes, physical well-being, social development, and improvement on motor difficulties. And yet there's much more of a need of evidence-based organized physical activities that may be adapted for autistic individuals. But there remains really a paucity of literature rigorously studying activities like this and the outcomes associated with these programs. So we seek in totality to improve identification, awareness, and treatment of these motor difficulties and study the benefits of organized physical activity programs broadly. Scientifically, to go into a little bit more detail about that, we know from many research that motor challenges that autistic individuals may face across a lifespan, but maybe will start at least in early childhood, particularly in that 5 to 6 years of age, or even earlier when development of fundamental motor skills. When there's challenges in those areas, it leads to more sedentary behaviors. It can have an impact on sort of quality of life well-being in terms of reduced peer interactions. So we think about that 5, 6, 10, 12-year-old who's running around on the playground, or maybe some that are more active in physical activities. And if a child has more difficulty in that area, it's less likely that they may participate in those activities, leading to a less likely probability of having those same sort of peer interactions or experiences that others may have. And we know that there's an impact, both negative impact on both physical and mental health and well-being due to these sedentary behaviors and reduced opportunities to interact in these same ways. So we know from research that autistic individuals and individuals with other intellectual and developmental disabilities are less likely to be physical active. There are higher rates of obesity and co-occurring medical conditions described in autistic individuals, not only because of things like medications and neurologic conditions, but because of more sedentary activity. And we also know that there's a lack of awareness and accessibility oftentimes to organized physical activity programs. So in terms of awareness, there may be these programs available, but not an awareness to families that they exist or that they're accessible to individuals with a range, again, of abilities. This study down below, put out about 3 years ago, just noted the sort of physical activity rates in children and adolescents with autism compared to the general population, finding particularly that those in the sort of 8 to 12-year-old age range were about 33% less physically active than their peers. So again, many studies highlighting this and really a need to better understand it. And even given the fact that we know that this can have a negative impact, we also know from some studies, particularly more systematic reviews and some other studies of pilot programs, that there are large benefits of organized physical activity for autistic children. And for the sake of sort of time and the kind of the scope of this, one thing that I left out today was more background actually on just the amount of evidence that we have that participating in physical activity, particularly in a group setting, can have a very tremendous impact on physical and mental health, studied in those who are typically developing or neurotypical, those without autism. But we know even from studies that it can benefit autistic children, adolescents, and adults, both those with genetic and non-genetic conditions. And so going back, the fact that we need more studies, more sort of rigorously designed studies to design these programs, and also the development of these programs was a major focus for our neurology node. So that leads me into describing the core project, which is focused on, and I'll give more information on the study design, on studying a expressive movement initiative program as a randomized controlled trial as an intervention study. So to give you some background, the Expressive Movement Initiative is a program that I was fortunate to start here back in 2019 with Dr. Emily Coker, who at the time was a medical student here at UCLA and is the founder of the Expressive Movement Initiative in Oklahoma, where she studied undergraduate. And I had the wonderful opportunity to meet with her when she asked to rotate to get more experience in pediatric neurology. And we talked a lot about some of the evidence and data that I just presented to you. And so with her help, we started the Expressive Movement Initiative here at UCLA. And the mission of the program is to provide an expressive outlet for individuals with developmental disabilities or identify as neurodiverse, foster mentorship and a sense of community among students, both participants and UCLA students, eliminate stigma and reduce the challenges associated with neurodiversity and disability. And one large aspect, and I'll describe also in our actual design of the study itself, is that the volunteers who participate in this program, the UCLA volunteers, receive training in neurodevelopmental conditions, what they are, what they often present with, disparities in care in these population, language in this population, and the benefits that we've described, the sort of evidence of benefits of organized physical activity. And what I'll say is when we establish this now, it's now a fully run student organization at UCLA. And I really give all full sort of credit to the undergraduate volunteers who've carried out this program quarterly every year since the start of this program in 2019. But moving now to the ARP, what we chose to do was, now that this program had been established and really targets many of the areas that we talked about in the previous slides, motor, getting children more active, physically active, teaching them specific supports around fundamental motor skills, endurance and challenge activities, which I'll go in more detail, but also providing a sort of group-based social scenario to engage with peers and engage with UCLA volunteers was sort of the perfect kind of foundation to study it as a clinical trial. So our study here as a part of the Neurology Node is studying the expressive movement intervention as a randomized waitlist control trial. Our study design, you can see here, our participants are randomly assigned either to a treatment group or a control group. We do stratify that randomization based on motor ability as screened by the DCDQ. And we also previously, what I'm going to present to you today are the results just of our pilot study. And we also stratify based on language ability. And we conduct pre and post outcome assessments, which you'll see as well. So here you can see we have our pre-test, which is a 2-week period, our dance classes, we have our treatment active group, and then our waitlist group, the post-test. And then we also offer our control group the dance classes as well, so that everybody can participate. And so again, now what I'm going to focus on are really the pilot data, the sort of later years phase we're currently collecting. And I'm very excited to present that sort of data in some time from now when we have fully collected that cohort. What I'll caveat with, but not spend as much time now that we are, 3 years into this, our ARP grant was awarded in 2020. As many of you know, the COVID-19 pandemic was ongoing at that time. So we fully had to shift this intervention program to completely remote both assessment and remote delivery, which of course was a big change in our study design than what we may have anticipated. So in terms of preparation for the intervention itself, we actually recruited 40 separate volunteers that would serve as a part of our research study, and 2 what we describe as creative or artistic directors that actually direct the dance classes. We trained all of these individuals on delivery of the expressive movement initiative, on autism, what autism is, on neurodiversity, and on adaptation of physical movements for a range of individuals with different abilities. As I noted, we shifted all of our measures to online during the pandemic. So our parents and our participants both completed online surveys and standardized assessments, both created and validated standardized assessments to measure motor skills, social communication, quality of life, adaptive skills, and physical activity level. We do have one direct mode of assessment that was done remotely to measure social communication, which is called the BOSC, developed by Dr. Kathy Lord, and her lab has been instrumental in helping us collect that data. And then, as I noted, these surveys were completed before and after the intervention. Quickly, in terms of our pilot study demographics, we had a total of 41 participants. As you can just see the breakdown of female and male participants. Those with autism diagnoses. We did have other developmental diagnoses also as a part of our pilot study, and predominantly because of the pandemic and the difficulties. We had anticipated recruiting, although we had hundreds of individuals who are interested. And then you'll see our breakdown of age range here, which for the pilot study was a much larger age range, again, secondary just to have access for families to this type of intervention during the pandemic. In terms of delivery of the intervention itself, the classes took place once per week over Zoom for 1 hour. Each participant was paired one-to-one with an undergraduate volunteer, and the classes alternated each week between a group class and a buddy class. So in the buddy class, they start out as a group, but then they go into breakout rooms and they alter across the floor to work with both their buddy for the rest of the class, and then at the end come back together as a group again. And here to the right, you can see our ME class plan. My apologies, I have a little. So here what you'll see is you'll see the warm-up. We start with the warm-up, then some across the floor moves, a challenge exercise. We take a break. We do the skill of the week, a game, some buddy time, and a cool down. And we have adapted the movements to be both for those who feel comfortable and ability to fully ambulate and conduct these moves, and those who prefer to do them sitting down, or those who may be wheelchair users, for example, or those who don't have the endurance or the comfort or the motoric ability to stand up and do across the moves. So we have 2 individuals demonstrating both type of movement activities. So in regard to the pilot data that I'm going to present to you today, what we found in 2 of our measurements, and I'm focusing particularly on the motor because that was a large focus and one of the primary aims for us, was we used, when we shifted to the online, the movement assessment battery for children checklist. And we found what you see here to the right are graphs. The first one is measurement in an unpredictable or dynamic environment in our active group, and then that same measurement in our control group. And lower score shows you that, shows improvement here, or indicates that you are scoring better on this test. And we found that there was a significant improvement in motor skills in the dynamic environment in our active group compared to our control group. We were very excited for that because purely we were trying to target fundamental motor ability. And of course, our hypothesis that if we are able to improve some of these, not only do we improve their ability to potentially engage in more physical activities, but perhaps in some way, which we have some direct measurements of, even confidence in or interest or motivation in participating in more of these activities. We measured social communication both through the BOSC and the SRS. Predominantly what we've looked at is the SRS. We did not see any significant improvements, but we did see a trend in improvement in a motivation and sort of social interaction as measured on the SRS. Again, we think maybe directly measured from the way that the dance class is set up to be paired one-to-one with the volunteer and the group in the breakout classes. We did also see an improvement in perceived stress in both the treatment and the control groups. And frankly, one thing that we outlined in particular in a paper that's under review, and that was led by Jeff Anderson, who is the research associate working on this study and a part of our ARP. What we really found both qualitatively from families responding to us was our program started really at the height of the pandemic when nobody was going out, and was ending particularly in that control period of time around a time that it was declared that we are sort of out of an initial state of emergency, or at least more free to travel and move around. And because of that, many families noted that, you know, it's the first time that they're having families visit ever them or meet the rest of their families. It's the first time their child has been invited to an in-person birthday party, or the first time in 2 years or a year. And so for that reason, we saw both attrition, but also what we imagine is probably reduction in life stressors that go beyond that we're capturing just participation in this program itself. So really helped us better understand what was ongoing at that time and maybe how we would tailor that in the future. So those are some of the exciting pilot results, which, as I noted in terms of dissemination, Jeff presented these at the AUCD conference last fall. And now we've recently submitted a manuscript, which we hope to see out soon. So our next steps in terms of this pilot study for the neurology node is we've transitioned the program now fully back to the UCLA undergraduate schedule, really allowing us an opportunity, the fact that this program is now offered quarterly, and to best embed both our active and our control participants. We have tailored our study measures and stratification for randomization and narrowed our inclusion criteria. So we've now narrowed it to those who have to have a diagnosis of autism, and narrowed our age range in terms of what we want to measure and what we want to show with this program itself. We're now very excited in the fact that we can bring individuals here for in-person assessment and go back to a major focus of both my research in the neurology node, which is using sort of a multi-method approach to be able to measure motor skills and social communication in individuals with a range of abilities. So both quantitative and qualitative approaches so that we can really understand what areas of difficulty might be and what areas may have changed with the delivery of this intervention. Also moving forward, as I discussed, a huge goal of the AARP is to collaborate and disseminate our research and help other researchers support building, research programs that they might be interested in conducting at their universities that fall under each of our nodes. So particularly with the neurology node, in conjunction with one of our CREs that's led by Dr. Gary Stobbe, he and Dr. Rayma Amin we are in the works of submitting an IRB to develop and implement the Expressive Movement Initiative program at University of Washington and Seattle Children's, specifically at the Alyssa Burnett Adult Life Center, which just from my reading and interaction sounds like a phenomenal center offering many activities to autistic adults and adults with other intellectual and developmental disabilities. So this specific program, we're going to expand now to adults, which historically has been a very largely underserved population when it comes to any type of interventions or delivery of interventions, particularly autistic adults. Another thing that we've done is we've shared our measures as a part of the Infrastructure for Collaborative Research, or the ICR, both measures for this and for other neurology studies, really as an effort so that if there are other researchers who are interested in using similar measures, they have sort of a platform to launch and don't have to start from scratch. So with that, I'm going to move on now to our next study. Just going to quickly check the chat if I can pull it up to make sure there is. All right, it looks like we're okay. And so now what I'm going to focus on is our sort of combined efforts with the neurology and genetics node, and going back to identifying and better understanding genetic conditions associated with autism and neurologic co-occurring conditions and treatment responses, or potentially what treatment responses could do. And to provide some quick background, with advances in genetic testing and a practice parameter now of the recommendation that any individual diagnosed with autism be offered genetic testing, we know that there are many genetic syndromes that are associated with autism or diagnosis with autism and neurologic co-occurring conditions. And including these individuals in research studies and using measures that can actually measure, again, going back to the conditions they may be facing, the symptoms they may be reporting, can really aid us in better understanding how these conditions present and how they can be supported and treated. And so to give some information on a study that was done, and I'm really going to highlight just one and not as much of the work that's been done here at UCLA in our lab. So this was a study done on a large data set and the Simons Searchlight done by the Simons Foundation that enrolls individuals, children with de novo mutations. And what they did was they looked at all sort of symptoms reported or behaviors reported on all of these different measures that were done. And what they found were those with de novo mutations showed greater likelihood of motor delays during early development, for example, later age of onset of walking, but really less difficulty in certain measures of autism core symptoms, right? Things like parent-related social communication difficulties or clinician-rated diagnostic certainty in later childhood. And so some of these data, and also what we found here at UCLA, where individuals with neurogenetic or genetic neurodevelopmental syndromes often meet diagnosis for autism, but what they show are fairly profound motor delays. And when you break apart their autism measures, for example, the ADOS, what you see is there's relative strengths in things that are more isolated social communication. So like a social smile that isn't highly dependent on motor functioning, right? Some gesture use or turning your head. And so better including more of these individuals in these studies, recognizing these differences and using measures that may not be fully dependent on the motor delays, or better studying how motor impacts the rest of their development, can help us better understand how autism may present in these individuals and how they may best be supported. So we had an opportunity to work with the ASXL Rare Research Endowment. It's a phenomenal foundation that reached out, because there's geneticists that we have here working with this foundation that reached out to me to give a talk at their conference on this area of research of why movement and motor skills are really important in neurogenetic conditions, neurodevelopmental conditions, and how it can impact overall development. And with that opportunity to disseminate some of the information, another thing that we engage with this foundation is the fact that at several of these scientific groups, and several with, I see a comment, Jonathan, but okay, we'll wait till the end too. Great, thank you. Really lends an opportunity to bring research to the families. So many of these are rare genetic conditions. These families are located across the United States. And in general, it can be difficult to access research at universities. And so overall, our goal is to bring these research studies as much as we can to a wide range, diverse population of individuals. And a really phenomenal opportunity is when these scientific research and advisory and family groups get together, is bringing our entire research team to them to be able to undertake some of these studies and better understand these conditions and the co-occurring conditions that go with them. So we decided to do that, and it was a phenomenal opportunity. It happened to be held here at UCLA. We brought an entire research team. We had a wonderful group of undergraduates who are interested in better understanding autism and understanding these genetic conditions and getting involved, which really allows us an opportunity to educate these trainees. And so what we set up there was to better understand neurologic conditions and neurodevelopmental conditions in specifically ASXL disorders, which I'll describe, and report these data back to the community. So this is entitled Examining the Neurodevelopmental and Motor Phenotypes of Bohring-Opi Syndrome, ASXL1, and Bainbridge-Ropers Syndrome, ASXL3. And these conditions are called chromatin modifying conditions, and they're caused by variants affecting proteins responsible for chromatin regulation. And these conditions have been described very frequently to be associated with autism or autistic individuals having these conditions, motor impairments and motor difficulties, and other neurologic conditions like cerebral palsy or epilepsy. And our goal really was to improve our understanding of these conditions and how these neurologic symptoms and conditions may impact neurodevelopmental outcomes. So we went to the research conference. We took a comprehensive medical and developmental history. We conducted both quantitative and qualitative motor assessments, quantitative gait analysis, qualitative motor assessments like MABC and DCDQ, the movement assessment battery for children, and the developmental coordination disorder checklist. And I conducted a full neurological examination on all of these individuals. And so to present you with some of that data, we enrolled 17 individuals with these conditions, 8 with Bohring-Opi syndrome and 9 with Bainbridge-Ropers, again, being a large number for a rare genetic condition, and at least a number enough for us to begin understanding some of the things that we wanted to examine. Quickly just orient you to this table. So this at least notes some of the items from the medical background. For example, age of first developmental concern, starting from 0 months to 1 year of age. And as you can see, several individuals reporting concerns in that first year of life. One of the reasons why we wanted to get this information is here at UCLA, we've had a genetics clinic, the Care and Research in Neurogenetics Clinic. And something that we found, Dr. Julian Martinez is a part of this clinic as well and director of the Neurology Node, is that there's a pretty significant delay from the time parents first note a concern and maybe access to or recognition by a provider. So we really wanted to highlight the fact that some of these concerns come on board in that first year of life. And when we disseminate this information back to healthcare providers, they understand that as well. We note that the prevalence of autism was about 25 and 38% in both conditions. However, I want to note here that I think it's likely that this might even be underdiagnosed, particularly in Bainbridge-Ropers. Again, one of the huge sort of impetuses to carry out this study in these genetic syndromes is oftentimes individuals with these genetic syndromes either do not get appropriate autism diagnostic screening, or there's confusion around whether or not the genetic diagnosis precludes their ability to hold other neurodevelopmental diagnoses, which can be very concerning because it can keep them from accessing the interventions and supports that they need. And then you can see the prevalence of epilepsy diagnosis and cerebral palsy, particularly epilepsy affecting those with Bohring-Opi syndrome, which we do know from the literature. So in some of our early data, what we found here was in our ASXL1 condition or Bohring-Opi, so what I highlight here on the right is the neurological examination, sort of an infographic of that, and on the left, just some of the highlights that we found. And we found that there was sort of a mixed presentation of hypo and hypertonia, which is very interesting from a neurologic co-occurring perspective, because you support those things in very different ways. And to have both of those in one individual leads us to want to better understand why that occurs and whether or not there's more sort of screening, such as neurodiagnostics, imaging that we may want to do to help support these individuals. But even to disseminate to providers, because you want to make sure you support both low tone and hypertonia in these individuals. We saw a slower gait and poor postural control. And those with AXXL3, we also found hypotonia, a larger range of motor skills and abilities, though, in this condition. And we found that those who reported an autism diagnosis did actually show greater difficulties in motor skills. What was particularly interesting in both of these conditions was the fact that families did note that the motor difficulties very much negatively impacted school activities, self-esteem, and social interactions. So going back to sort of the neurology node priorities and hypotheses, that if we can better understand some of these motor difficulties, characterize them and make them known, and show how they impact neurodevelopment, that there is going to be more of a reason to both identify them and support them to help broader developmental outcomes. What I really want to highlight on this slide also is Dr. Maya Ayub. She's a phenomenal child neurology resident here at UCLA. And in regard to mentorship, she's a trainee that we've been mentoring in this project, who presented the data at the INSAR conference, the International Society of Autism Research Conference in Sweden in the spring. And now we have a paper with this data under review as well. So moving then from this sort of study, I'm going to go talking a little bit more and extending of this study about community engagement and disseminating information on best practices to caregivers, primary care, and specialty providers, something that we want to work on more in the neurology node moving forward. What I want to highlight here is we have several webinars, such as this one, that take place as a part of the ARRP, that really disseminate some really interesting and unique information. Just highlighting some of the neurology webinars that we've had on motor, on epilepsy, on sleep difficulties. We have the ARP Lend lecture series as well that was focused on epilepsy. And I just put the YouTube link here so you can access some of those. But another big goal of ours is disseminating our research findings to the community in as much real time as we can, even prior to the time that it's being published, at least well-reviewed, but published, just because that can take longer. And what I highlight here is just the opportunity that we took, that once we gathered some of the data on these genetic neurodevelopmental syndromes, not only publishing it, but writing it up in lay terms. For example, you see on the right for the ASXL Rare Research Endowment for the community itself, that they were able to disseminate as a part of their newsletter. And from that time, we received comments or outreach from several families who say that this helps them better understand maybe whether or not they need to go see a neurologist, or information that they can provide to their caregiver. And as a part of the ARP, it is fundamentally important to us to disseminate this information back to the community. Now, highlighting back again, as I move through, as I noted, like I said, I'm going to sprinkle throughout, going back to not only expansion of neurology node priorities, but expansion particularly through mentorship and supporting researchers undertaking studies related to the neurology node. And I'll add a sort of subpoint to that I don't have here, but also supporting researchers who may not have historically been doing research in autism, for example, but have some interest or found something that they think is very important for the autism community as a part of their clinical or research practice. I do want to highlight here that we have scholarship applications that we put out applications for yearly. We just announced our cohort this year, our phenomenal cohort. And so I want to just note for everyone to keep an eye on that, and to also note that on our website we note that we can serve as project and career mentors as node leaders to help formulate, shape, and support your project, of which I'm going to highlight one of these studies, but we've done for other studies also. So I'm really just going to give a brief kind of view of this study, because mainly I want Dr. Cho to be able to highlight this study when she has her findings, but I want to make you all aware. So Dr. Medio Cho is an associate professor of neurology in the Division of Pediatric Neurology at UCLA, and also the associate director of the UCLA Steve Tisch Brain Sport Program, and a neurologist in our autonomic dysfunction, or our POTS clinic, our postural orthostatic tachycardia clinic. And what she was curious to know from her own clinical experience is, what is the link between autonomic dysfunction and autism? Because she had found in her clinic, her POTS clinic, that there were several autistic individuals who were coming to her clinic with these symptomatologies, and several individuals who had also received later diagnoses of autism. So as just a quick highlight, and this slide, and I should have noted here, but this slide is courtesy of Dr. Cha, is there's very limited research describing autonomic difficulties in autism. So one thought could be perhaps there's an increase in sympathoexcitation and a decrease in parasympathetic activity, leading to sort of a sympathetic vagal imbalance, leading to more of higher cardiovascular activity. There have been some mixed findings in terms of pupillary response in this sort of sympathetic parasympathetic excitation. Some of her hypotheses may be hinged around maybe a contribution to some of the neuropsychiatric symptoms or co-occurring conditions we see in autistic individuals. Maybe an anxiety could be due to a heightened sympathetic response to more stressful stimuli. Perhaps a lower parasympathetic tone could create greater symptoms of anxiety, right? A sort of physical impacting social interactions. In more severe cases, there may be sort of sympathetic underactivation, except when engaging in more maybe self-injurious or self-stimulatory behaviors, or alternatively, this sort of sympathetic hyperarousal, in that some of these repetitive behaviors may be calming. It could also be that there's an effect by long-term use of psychotropic medications on parasympathetic and sympathetic response. But she also notes that there's a higher prevalence of cardiovascular mortality and morbidity in these populations, hence her interest to really study these in more detail. So her scholars application, which she's working on now, is characterizing POTS in autistic children. And aim one is to improve our understanding of POTS in autistic children and describe the range of phenotypes for POTS and genetic syndromes in autistic individuals, or that overlap in POTS and genetic syndromes. And aim two is to understand treatment needs and develop approaches towards therapy goals through a support group tailored toward autistic individuals with POTS. So expand our understanding of the treatment needs of autistic individuals with POTS and develop appropriate modifications to current standard behavioral interventions recommended for POTS patients. And this is done with Madison Harris, who's an occupational therapist in the POTS clinic, and they've already created the intervention, are working towards that tailoring. Just a quick in terms of the description, what they're doing. They've created a database with a targeted search of the electronic medical record of POTS, autonomic dysfunction, autism, both clinical and community-based diagnoses, Ehlers-Danlos syndrome, because there's been some maybe question of overlap there, and hypermobility. They're including surveys, both a composite autonomic system score, assessment of quality of life, autistic traits and abnormal sensory experiences to determine symptom profiles, demographics, clinical history and presentation, doing more direct objective testing of cardiac and autonomic features, and then of course, testing the treatment response and the treatment group that they're tailoring. So I'll just leave it at that, but I think this project is very exciting. Again, it expands sort of these recognition of autonomic, neurologic conditions that might even go into more broader health conditions in autistic individuals, and just really improving our understanding of these across a lifespan. So speaking of lifespan, that's really what I'm going to end with now, which is our priority of understanding neurologic conditions in autistic adults and examining the data that's out there and disseminating this information. So this work is being done in conjunction with the Health Services and Systems Node, Dr. Lindsay Shea, and we're looking at the prevalence and correlates of neurologic conditions in a national sample of Medicaid-enrolled autistic individuals with and without intellectual disability. So going back now, and I'm not going to go in detail again because I described this, but just re-highlighting the sort of really high prevalence of co-occurring neurologic conditions in autistic individuals. But now I'll highlight a little bit more about what's the impact of those, right? They're not only prevalent, but they're very pervasive to physical health and well-being. So we know that there's detrimental impacts of seizures and epilepsy, both in cognition and behavioral and neurodevelopment, particularly in early life. Sleep difficulties can impact cognition, regulation. They can exacerbate co-occurring behavioral conditions. They can exacerbate physical health and well-being, obesity, metabolic effects, and worsen quality of life. And we've already sort of highlighted, so I won't go again in depth, but we know what motor difficulties can also do, which increasing sedentary behavior and impact a broad range of areas in terms of physical health and well-being for autistic individuals. We also know what I'll highlight, which I didn't highlight earlier, in more recent studies, very recent, is that there's a higher prevalence of these adult onset neurodegenerative conditions in autistic individuals. So data has shown that Parkinson's disease, for example, studies show that the odds ratio of Parkinson's disease in autistic individuals is about 6.1 compared to the general population. That's a huge higher odds ratio compared to the general population. There was one small cohort study of 37 autistic adults in which 37 met criteria for Parkinson's disorder. Again, they noted the fact that, you have to take into account where it could be confounded by those individuals who are taking medications such as Abilify and Risperidone. But again, these sort of studies starting to show us these higher prevalence of these neurodegenerative conditions, also such as dementia. One study in which, led by actually Dr. Shea, in which the prevalence of dementia was about 4% in autism and 5% in autism with those with autism and intellectual disability, compared to the general population, which was about 0.97%. So given some of these initial studies, there's still some major gaps in our understanding. So there's limited systematic studies on autistic adults. There's a lack of knowledge while there are higher rates of these conditions. Many of these studies examine only one condition, although many can co-occur. There are overall limited resources and guidance for adult providers to care for these individuals. And our conjunction with the health services and system was, how can sort of Medicaid really prepare to support service delivery to these groups? So how can we query Medicaid data to better understand how we can support these groups? So our methods for this ongoing study is to look at a national Medicaid claims data from 2008 to 2016 for all enrolled autistic individuals, and a random sample of Medicaid enrollees without autism or intellectual disability claims were selected. We had a cohort who contributed at least 9 months of data, and age 40 plus were included. And as you can see in our sample size, we had autistic individuals in separate groups with and without intellectual disability of 16,000 and 29,000 respectively, and a comparison group of Medicaid enrollees without either of 406,000. So really an opportunity to query really large sample sizes. And then we looked at the prevalence of adult onset neurodegenerative conditions and these co-occurring neurologic conditions. These are quickly just the demographics of the populations. Just nice to know that we have a range, but I should note here, again, the predominance are of white individuals when we consider race. So really need to work on our understanding of diversity, how diverse populations present with these conditions. And when we look at the data itself, so what I'm going to orient you to in this graph is on the left are the neurologic conditions that we're studying on each of our rows. And our columns indicate our group with autism only, those with autism and intellectual disability, and then our comparison group of no autism and no intellectual disability. And as we move through the table, in our first group, you'll see the sample size. And in autism, what you'll see is that the rate of Parkinson's disease is 2.3% compared to 0.5% in our control group. Our rate of dementia is 12% compared to 2.7% in our control. And then our range of epilepsy is 11%, 19%, and 16% compared to 4%, 12%, and 6% in our control group. What we look at, what I want to point out particularly about our autism intellectual disability, is that what we find is that in those with autism and intellectual disability, epilepsy rates increase quite a bit to 35%. Sleep doesn't actually interestingly increase, about 14%, which is likely more of a function of those who may not be receiving diagnoses, I'm assuming, of sleep difficulties, and motor disorders jumps up to 27%. What's nice actually to see here, and also important, is replication of previous data. So there have been several studies looking at some of these neurologic co-occurring conditions, particularly epilepsy and autistic individuals. But sometimes these studies are affected by what we call ascertainment bias. So they're done predominantly in maybe clinics seeing tertiary hospitals, seeing individuals with complex medical conditions, maybe showing us higher rates of epilepsy, or those only in adults or those only in children. And by us being able to query such a large sample size with and without intellectual disability, we're able to show that these rates of epilepsy are fairly similar in young adults as we've seen in other studies. So particularly kind of replicating findings of about 11% of epilepsy and autism. And when you add ID, that rate going up, because intellectual disability is a known risk to increase epilepsy rates in autistic individuals. So kind of re-highlighting those results again, the rates of co-occurring neurologic conditions and adult onset neurodegenerative conditions are elevated in autistic adults, even in a younger, diverse sample, right? We think about often neurodegenerative disorders presenting at 60 years of age. We included 40 and older. We find that individuals with autism and intellectual disability have higher rates of co-occurring neurologic conditions. I want to note that most of these individuals were enrolled in Medicaid for years and were enrolled via disability eligibility criteria. And so what are the implications of this? We know that there's increased risk by co-occurring condition can support providers in identifying factors that could be screened for or related to later neurodegenerative concerns. That's sort of step 2 of what we're doing, which I didn't fully highlight here and slightly for the sake of time. We know that there's thousands of autistic individuals with these conditions are insured by Medicaid over long periods of time, and services and supports for their care are needed. So models of care that can support complex medical and behavioral supports for autistic adults really need to be and should be prioritized. And we can provide and disseminate some of these data to adult providers, both primary care and subspecialty providers, really hopefully disseminating the information that these conditions need to be well screened for in this population, which can often be dropped off during transition of care from adolescence to adulthood. So with that, I'm actually going to go ahead and summarize for our neurology node. Again, going back to our mission, which I showed, the goals of the node are to improve identification, awareness, and intervention of co-occurring neurologic conditions in autism, with a focus on those that are understudied and related to physical health and well-being. We plan to continue to very much expand these areas of focus, and I look forward to presenting that updated data to all of you. Our goal very much is to support our collaborating research entities and scholarship applications to expand the work of the neurology node and to continue dissemination of information to caregivers and providers. And that's really going to be a focus of ours. It has been now, but really even bolster that moving forward. And my hope in presenting these data can really bolster that as well. So I very much appreciate, thank you for attending. Thank you for your time. And I want to highlight that the link to view this recording will be mailed to all registrants. I might be taking Nellie. Sorry, am I taking your slide, Nellie?
No, not at all. Not at all. I appreciate that. Go on.
Our next webinar is Tuesday, September 19th, again from 4 to 5 p.m. Eastern time. I think it's going to be really exciting. It's going to be Caitlin Coffer-Miller and Jessica Rask presenting on the health of autistic people during the COVID-19 pandemic and the National Autism Indicators Report findings. And that QR code right there will allow you to register. So thank you so much for your time today. And I'm happy.
Thank you, Rujuta.
Yeah.
I don't know if you saw Jonathan's comment in the chat, if you'd like to.
Yeah, I'm going to actually stop sharing for
that first for follow-up content.
You know, Nellie, sorry, you're freezing a little bit. I'm going to go.
Apologies, I think I froze, Rujuta. I don't know if
yeah, you
me.
did. That's what I was waiting for you to come back online, but I saw Jonathan's
Thank you.
comment as well. Yeah.
Okay, great.
So Jonathan, I'm very happy to share my information. I'll actually put it in the Q&A and please feel free. I think that's, well, maybe I can't. Can I put it in the chat? Here we go. You know what? My chat is for hosts and panelists, so I'm going to let Nellie share. It should be on our website too, which is RBHATT.
You can change it. You can also change it, Rujuta. If you go to the chat under 2, you can change it to everyone.
Ah, great. Thank you.
I also did that earlier when I was trying to send the slides.
Okay, awesome. Thank you. I appreciate that.
There you go. Yeah.
Jonathan, please feel free to reach out. I would love to talk to you about that. I think that's a great idea. That's one of our goals, is really widely establishing or supporting other organized physical activity groups, programs, providers, and measuring outcomes. And even if it is just providing sort of our experience and the measures that we've used as a starting point for you to review and take a look at. I've had several conversations with investigators at both CREs and non-CREs who maybe weren't necessarily ready to take the first step to have an entirely randomized controlled clinical trial, but just wanted some support and information on the type of measures we'd use or literature we had looked at, and challenges and strengths we'd faced with some of those measures. So please feel free to email, and I'm happy to email you back that information and connect.
Wonderful. Thank you, Rujuta. I know we have 5 minutes left for anyone to think of any additional questions if they have any. For now, I'll go ahead and throw up the survey in the chat. If anyone has any feedback for us for future webinars, you can leave any comments or feedback via the link that I just put in the chat.
Great.
So if there aren't any additional questions or comments, I'd like to thank Dr. Wilson again for joining us for today's webinar, and hopefully we'll see you all next month.
Great. Thank you so much for your time. Have a wonderful rest of your day.
Thank you.
Right.